Hello and welcome. On behalf of CME Outfitters, thank you for joining us today for our program titled Meeting the Challenge, Improving Diagnosis of ALS. This is the first of three activities in the CMEO Snack Series supported by an educational grant from Biogen. I'm Dr. Jinsey Andrews, and I'm the Director of Neuromuscular Clinical Trials at Columbia University. I'm here with my colleague, Dr. John Novak.
I'm John Novak. I'm a neurologist out of Columbus, Ohio, and I currently work for Ohio Health, where I'm director of the Ohio Health ALS Clinic for approximately the past 10 years.
Thanks so much for joining us today, Dr. Novak. Our goal is that after this CMEO snack, you'll be able to recognize the challenges in diagnosing ALS. So first, let's talk about ALS, amyotrophic lateral sclerosis. Dr. Novak, what's the population of ALS in your area like, in your practice?
So most of our patients are undergoing, a similar process of motor degeneration. That's what amyotrophic lateral sclerosis is. So, they're having progressive weakness secondary to loss of motor nerve function from both the upper motor neuron, so the nerve that goes from the brain to the spinal cord, and the lower motor neuron going from the spinal cord out to the muscle. And so this gives them a very unique picture of having atrophy from the lower motor neuron issues and spasticity and hyperreflexia from the upper motor neuron. So, these patients are progressing at variable rates, but they are typically getting worse. It's essentially paralyzing them slowly, one limb at a time. Sometimes they start in the arm, sometimes they start in the leg, sometimes they can start in the bulbar muscles. But, across the whole, they are all getting worse and give this mixed upper motor and lower motor neuron pathology, which is very important to our diagnosis and what we have to deal with on a clinical basis.
Yeah, I know for us who are specialized in neuromuscular disease and see many ALS patients, pattern recognition is important. But for a lot of our colleagues that may not specialize in ALS, it might be not as common to see ALS. And so people often ask, how common is it? Is it a rare entity? How many patients are there with ALS?
Currently, most studies will say about 2 to 5 cases per 100,000 people. So certainly not common, but common enough that if you're working in a large city, or a large health system, you're going to run across it. Even as a non-neurologist, you'll eventually run across somebody with ALS. They can present at any time. Most patients, typically in their 60s, would be the highest incidence of ALS, but we have patients in our clinic in their 20s, and we've diagnosed patients in their 80s, but typically kind of mid to later, middle ages are more likely to have it, but it doesn't really seem to matter. It could happen at any time and to anyone. There's not a real strong male to female predominance, any ethnicity. We pretty much say anything can go with ALS.
Yeah, I think you make a really important point about the variable nature of this one disease called ALS. It's really different from person to person. And, I think from my perspective also, I have a lot of people who might have hand weakness and be misdiagnosed as carpal tunnel, or they might have seen the orthopedic surgeon. So often I talk about ALS to people outside of neuromuscular disease because, they might run into the people possibly with ALS because the symptoms mimic many other disorders. So it's really important to be aware that how ALS presents and that it does exist. So if someone does have ALS, what are some of the things that you emphasize as treatment goals when you see them?
So currently, since we don't have a cure, we can't fix these people. We are really trying to slow progression with medications and just physical intervention. We want to slow progression of their disease to as slow as possible, and we want to improve quality of life. We want these patients to, if they're going to live 3 to 5 years on average with ALS and sometimes longer, we want them to be safe. We want them doing what they want to do, and we want to try to improve that quality of life as much as possible through their disease state.
Yeah, I agree. And I think it's really important when you're managing ALS to really focus on the individual because, people can present very differently and their needs for their care can be different based on where they're affected or what type of ALS. And actually, let me take a step back and ask you, there are different ways that people categorize ALS, and so people often say they have sporadic ALS or they might have familial ALS. Could you explain a little bit about that?
So sporadic and familial is just indicating, whether there is a family history. And there are certainly inherited forms of ALS that we can test for specific mutations, and we can, confirm a very specific mutation in a family that will be causing ALS, but that only represents maybe about 10% of ALS cases. So the far majority of them are sporadic, which would mean it just starts randomly. We don't know why, we don't know what triggers it in a patient. And there's, typically no obvious risk factors or trigger for why they started suddenly losing motor nerve function. But in those 10%, it's great diagnostic tool to use genetics testing, but in the other 90%, we are a little more limited on how to diagnose and approach those patients.
So with the discussion that we just had about sporadic and familial ALS, and also we just talked a little bit about the overview of ALS, we touched on a couple of things about how people present. So I wanted to talk a little bit about ALS disease progression. What are some of the common complaints that people come to you stating that they have when they first present?
So the things that really concern us as a neurologist, and especially someone who does a fair amount of ALS, is anybody who says they're getting progressively weaker in the absence of pain and sensory symptoms. So this is a motor nerve disease. It's going to affect the motor nerves. There's not a lot of pain involved early on. There's not a lot of numbness or tingling. Just they have a limb that's just getting a little weaker than everything else. And so it can be very subtle. It can be, kind of a sneaky, insidious type onset for patients, and it can start anywhere. So leg or arm doesn't really seem to matter. The things that really kind of, throw up red flags are people who are getting a little bit weaker. They don't have a reason for it, and they're getting things like cramps, and they're getting fasciculations or little muscle twitches, all things that would point towards a neurogenic process as opposed to an orthopedic or, other thing that they might blame it on, a bad knee or a bad back or, rotator cuff things. Like, these don't hurt. They're getting weaker and they're getting kind of twitchy or crampy, I think is a big thing for early on for our bulbar onset patients. So if it starts in the throat muscles initially, they're typically noticing a little bit of slurred speech or having to really concentrate to get words out right. So they might be like other people might not notice it, but they have to force themselves to speak clearly, especially if they're getting tired. So towards the end of the day, it may be more noticeable. And then also just, mild dysphagia. So they're choking a little bit when they're not paying attention. Maybe they're trying to talk and eat at the same time and they choke on liquids. Things like that are pretty frequent early on. And at least, from my standpoint, kind of point towards, this might be in the nerve and this could be concerning.
Yeah, you talked a little bit about bulbar onset ALS and how that can be affecting the bulbar muscles, which is the muscles that help you speak and swallow. The presentation, when someone comes in early, obviously there is variability about how their body is affected and where the disease actually starts, which is what probably contributes a lot to the difficulty in diagnosing people early. Can you talk a little bit about how that presentation differs in people when they present early in their disease?
So for bulbar patients, sometimes it's subtle and other people don't notice it. They can have tongue fasciculations, which is a very specific thing that isn't seen in a whole lot of other issues. So you can see the tongue actually twitching if someone takes the time to look in their mouth and see it. The choking is typically pretty mild to start. The weight loss can be common because they're starting to limit what they eat because they choke more. And so those patients might start losing weight a little more rapidly, although all of them can lose weight because of muscle loss. But specifically, those patients, we worry about the dysphagia and dysarthria and sometimes have pseudobulbar affect. So that's more common in the bulbar patient where they lose control of their emotions. So they might laugh at something that's sad, or they might cry at something that's funny, or they just have such an exaggerated reaction to something that, they can laugh until they choke at something that's not that funny. And that can be seen more in the bulbar patients and would be a sign that there's some sort of, neurodegenerative process going on, not just a physical issue with the muscles of the throat.
Yeah, that pseudo-bulbar um, affect, right? You mentioned, is that easy? It's the emotionality
Yes.
and emotional lability. Sometimes people will use that term. It can occur in people who have bulbar weakness, and there is FDA approved therapy with the indication to treat that symptom, which is dextromethorphan and quinidine, which can help reduce the number of episodes per day for that. And typically, from my perspective, when I deal with those individuals, usually I will talk about treatment if the patient is bothered by it. Often family and friends will come and say the symptom exists, but until it affects the person themselves and their social interactions, that's usually when I initiate treatment for that. What about limb onset?
So limb onset, typically they're losing, mobility or strength. Most often early, it's in a single limb. So this does not start, kind of just blowing up on all places at one time. Foot drop. So maybe they're tripping over their, toes when they walk, or their hands getting weaker and they can't open jars. Things like that pretty early on. As they progress, you start to see more atrophy. So then patients will start to notice that a leg looks thinner than the other, or their hand is getting atrophy in some of the muscles. And so that becomes, a little more evident, typically still somewhat focal. It's going to be in one limb with slowly starting to affect the other limb. So a lot of patients will say, my arm was a little weak and I was having trouble painting. And then I started to notice some muscle loss in this arm. And now this arm's starting to do the same thing this one did. You hear that a lot. Yeah, this arm's doing the same thing this arm did, as it spreads. So as the disease progresses, it's spreading regionally and, from an anatomic standpoint, but it's also spreading or progressing in a severity. So they're getting weaker in one limb, but also starting to involve other limbs as the disease goes on.
So when patients present, they have varying degrees of functionality. And so what do people look like if they have confirmed ALS versus like early suspected ALS? Or do people come with significant disability?
Yeah, a lot of times by the time we get them, by the time they're seen in an ALS center, they have significant disability. So, I think anymore, it's somewhat rare to see a patient come walking in and be in pretty good shape and that be their first visit to an ALS clinic. Many patients have significant disability. Looking at kind of an early middle late stage, sort of just a rough guess, I would say most of our patients are in the middle stages where they're already falling, they're already using transport chairs to get around, losing significant amount of their body weight due to dysphagia and muscle loss. I think is very common. The functional rating scale that we use to look at how someone gets through their activities of daily living, on a 48-point scale, 48 points being completely normal, so you can walk, you can do stairs, you can eat okay, you can write, and your breathing's pretty normal. Patients are often well in the mid-30s, which, looking at that scale, is a significant drop in functionality before they're even diagnosed or upon their first visit with us. So that delay in diagnosis is a problem, and kind of why we're here to talk today.
Yeah, I agree. And I do find that tool where you rate the function, the ALS functional rating scale, very useful. It helps to kind of see progression and kind of give an overall impression of daily function. You mentioned the different ways people are affected when they first come, limb versus bulbar onset, and how subtle these symptoms are. Are they often misdiagnosed when they see you?
Yeah, I would say, in clinical practice, we see a lot, either undiagnosed or misdiagnosed. In studies, over half are given an alternative diagnosis. The top ones typically being stroke, especially for a bulbar onset, maybe they had a stroke, but lumbar stenosis, cervical stenosis, carpal tunnel syndrome, and then, variety of orthopedic issues
Sure.
in that limb are typically the ones that patients will get earlier on, and potentially treated for. Many see, orthopedic surgeons, neurosurgeons. I'm often the fourth or fifth doctor, and studies have shown patients typically see at least 3 before they get a diagnosis of ALS, and a fair amount of them have surgeries that they didn't need and weren't the appropriate treatment for them.
So it's understandable. I mean, I have that same experience when I see people for the first time. They've been told different things, especially if the symptoms were subtle. And remember, you mentioned it's painless weakness that progresses over time, and sometimes it creeps on people. And do you think that this contributes to some of the diagnostic delay?
I think it does in probably multiple ways. The kind of 65-year-old male who just has a little bit of weakness in his arm, doesn't go to a doctor very quickly. And so they may delay the diagnosis themselves as they just think, oh, I'm getting older and I'm just going to deal with it and I'm going to get through and it'll get better. They start going, a lot of patients will start exercising it more and like, I'm going to make it stronger because it doesn't hurt. So they just think it's just weakness, and they can overcome it. But then as it starts to spread, it becomes a little more obvious. But even in the patients who present to their primary care physicians, they still have a lot of delay in getting to see a neurologist because the primary care physician might do a very similar process and say, well, you're getting older, it's a bad knee, it's this and that. So it can look like other things, and it can certainly take a long time to diagnose. Studies showing on average, 12 months to 17 months. In our one study that we have here, the median time to diagnosis was 12 months for a patient, where their average diagnosis was 17 months from the time of onset to the time they were told this is what they have. And in this study in particular, out of France, they lived for about 3 years. And so their survival was 3 years. They spent, up to 17 and a half or 17 and up to more without a diagnosis. So that is a significant delay for a variety of reasons, but one of which being it just starts slow and it just slowly gets worse.
Why do you think diagnosis takes longer for some patients than others?
Uh, so we know rapid progressors will tend to get diagnosed, sooner, which makes sense. If they're, progressing and they're showing signs all over their body, then it becomes easier to kind of pick up on a disease of the nerves as opposed to just a single issue. Particularly bulbar patients. So the second graph here on the slide shows bulbar patients in red and spinal onset ALS patients in blue. And as you can see, the red line's going up much quicker. Patients are getting picked up sooner. And so you have a high percentage of patients with bulbar ALS diagnosed in about a year, and I think that's just due to it's more severe. People are choking, they can't talk. There's also less things that would affect these muscles. So you'd have a kind of a narrow differential, and maybe, docs are kind of more worried about someone who's choking on their, drinks and on their own saliva. So those patients might get referred faster and worked up faster, and it's just a little more obvious. Whereas spinal patients tend to have the back surgeries, the neck surgeries, and other things where you can blame something else and drag out this time till diagnosis for quite a while.
Is this something, I mean, I know when I'm at a specialty center for ALS, and certainly in my experience, I see people anywhere from 6 to 12, but I have had 6 to 12 months from their symptom onset, but I have even had people 1 year, 2 year, one patient I had come 4 years after their symptom onset because they were told different things. Is that something that you experience also at your clinical practice?
Yeah, fair amount, in fact. I mean, I think the studies showing that, it will take a year or so for people to come seems pretty spot on for what we see. It definitely takes quite a while to get there. I see that in the clinic. As far as in the literature, there was a recent review at a Cleveland clinic where they looked at about 20 some studies looking at the diagnostic delay and how often how fast did patients get in. And, it kind of is not all that variable. Patients typically will start showing some sort of symptom, but may delay 3 to 6 months before they come to see their primary care physician. So that's the patient that's just waiting. It's going to get better. It's nothing major. But then from that point, little over half are referred to neurologists, but almost half, 40% across the multiple studies, were sent to other specialists. So this is missing the boat from the very beginning. And these are patients who are referred to orthopedics and neurosurgeons and ENT doctors because the primary care physician or whoever their first contact was, the referring doctor was not even thinking ALS. They weren't even thinking it was a neurologic condition, which really kind of shines a light on the fact that we're going down the wrong road. And so from there, those patients are sometimes then sent to, typically they get to a neurologist eventually. And across these studies, their average time to diagnosis was 10 to 16 months. So it certainly does bear out that it's a year plus before people are diagnosed, especially if they are misdiagnosed with something else. So those patients take even longer. Those are the one seem to be the biggest modifiable variable in someone's diagnostic path was, did they get told they had something else? Because now they're treated for that. And that just delays everything months and months and months down the road until you finally realize, oh, wait, that wasn't it. And then they circle back to neurology. So I think, that's a big thing that we need to do better at.
Yeah, I think it just highlights the importance of ALS being on people's radar, whether it's the PCP, the physical therapist, orthopedic surgeons, neurosurgeons, and other disciplines. And, even from my perspective, I've had people not referred to an ALS specialty center because there's been perception that there won't be much else that could be done. And I think that's part of the series here, and also for us being here to talk about why it's important to diagnose early. But let's go back a minute and ask the basic question, like, why is it so hard to diagnose? Why is ALS so hard to diagnose?
On the surface, the biggest thing is we don't have objective testing for ALS. So you don't have a biomarker that you pull out of the blood and it comes back with a yes/no test, or even like a concentration of something that will definitely say it. We're getting better at some of that stuff, but we're still a ways away from it. So it's a clinical diagnosis. So you need to be comfortable with that sort of clinical exam, the diagnostic criteria, and giving that diagnosis. So in the absence of a test or an objective measure, it's up to us to clinically evaluate the patient, rule out other things. So you have to go through this big exclusion process of, well, it's not this, it's not this, it's not this, it must be ALS, which is very, can be a very difficult process and very intimidating to a doctor who doesn't do it a lot. Our diagnostic criteria in particular offer some hurdles, as people that don't use them very much don't like them. We were classically taught the Escorial and the Awaji criteria, and these are complicated diagnostic criteria by most doctors' standards. We don't diagnose somebody with ALS a yes or no. This is criteria that categorizes people on how certain we are. And so you get put into now 3 different categories as possible, probable, or definite ALS. And it really comes down to, do you have this mixed upper motor and lower motor neuron pathology, and how many areas of your body do you have it? We have cranial, we have cervical, we have thoracic, we have lumbar. And if you have it in 3 of those 4 areas, that's definite. 2 essentially is probable, and 1 is possible. And so there's criteria for each of what's upper and what's lower, and they get kind of subjective. Is this really hyperreflexia for the upper motor neuron? But it gets very complicated, and docs don't like it necessarily, and there's a fairly low inter-rater reliability with it because it is somewhat subjective. So until we can get better biomarkers and better objective measures, I think it's always going to be a difficult diagnosis, especially given how grave the diagnosis is and the comfort level of telling someone, I think you have this based on me hitting you on the knee and testing your muscles. That's a difficult thing to do.
Yeah, I agree. And there's a lot of work in the field right now to evaluate potential biomarkers, whether it's in the serum or whether it's in the urine. to diagnose ALS or even look at disease progression biomarkers, which are also critically important because once someone gets diagnosed, the next question often I'm asked is, what can I expect for disease progression? And as we talked about earlier, disease progression can be really variable, and 10 to 15%. I don't know how it is for you, but certainly I've seen in my career up to 15% of people who have slower disease progression and are longer term survivors for the disease. I also wanted to ask, in terms of the diagnosis, I've been talking to physicians and they say, well, okay, so we need to improve the diagnosis. Why should we move people to an ALS specialty center quicker? What can you do? What's the impact, if we diagnose and send? So why does it matter? What are the consequences of delayed diagnosis?
There's a lot. I think the biggest thing from a patient standpoint is just knowing what they have. These people are getting weaker, they're falling, they're having all these issues, their families are concerned about them, and essentially they don't know why. And I think that's, even if I have to give someone a bad diagnosis, I think they would almost rather have a diagnosis at some point than just to continue to be told, I'm not sure what's wrong with you, go see the next doctor. But even beyond that, we have ALS centers and multidisciplinary clinics that are set up for patients with ALS. And these are centers where we have physical and occupational therapy to address their mobility and activities of daily living, respiratory, to test their respiratory parameters and adjust, non-invasive ventilators for them. Dietitians and speech therapists who will work on swallow and communication and their nutrition, as well as social workers, to help with their mental well-being. And we have these centers, but if you don't have a diagnosis, you're not going to one. And so, these places are associated with improved quality of life reported by patients and improved survival. They live longer going to these clinics and seeing experienced people. And so trying to navigate this on their own at home without having a diagnosis and being sent there is really, suboptimal care. Like we want these patients in centers where they feel like they're getting cared for as much as possible. I might not be able to fix them, but at least they feel like they've got a team surrounding them that can help them live longer and, hopefully happier lives with what they've got.
Yeah. And I think, and I wanted to point out that, obviously getting people earlier in their journey, they have less clinical disability. And there's two really major factors in their care. One is trying to use disease modifying treatments and also clinical trials. Can you comment a little bit about that?
So patients who don't have a diagnosis or, maybe have a possible diagnosis from someone but aren't treated, are missing out on disease modifying therapies that can potentially slow things down. We don't have a cure. And that's unfortunate, but we do have two medications that are approved by the FDA to, essentially slow things down is how we look at it or how I explain it to patients. Riluzole has been around for decades now and shows, varying degrees of increased survival with it, but we know that if you give it earlier, it tends to help more. It's decreasing excitotoxicity to the neurons. You are trying to slow down the loss of those motor nerves. So it makes sense to get that into a patient as soon as possible to try and slow it down. And then Radicava, which is a lot newer, is basically decreasing free radical damage, I guess is the best way to look at it, in those motor nerves. And in a similar sense is trying to slow down progression of the disease, slow down their functional decline. And so getting someone earlier, would help them later. And even with that one in particular, with the Radicava, you have to be early in the disease course. You have to have near normal respiratory function to even qualify to get the medication. It doesn't help later on. So we want patients treated earlier. It's going to be better for them in the long run. And then as far as clinical trials go, patients with ALS have a very narrow window to get into a clinical trial. They're getting very stringent on, you need to be, symptomatic to the point that you're probable or definite ALS based on those criteria, but not so bad that you're not going to show an effect if we're trying to slow it down with our medicines. And so, whether they've had the disease for too long, A lot of trials cut off at maybe a year and a half or 2 years, depending on the trial. And so if they've had the disease for too long, they'll miss the boat for a clinical trial. If their respiratory function has declined too much, they can, not qualify for a trial. Or if they've just progressed too much and they have too much functional disability, they might not get into it. So it's harder to get patients into trials, and they're missing out on potential, life-saving or altering medications because of the delay in getting that diagnosis.
Yeah, I think that's a really important point. I mean, the earlier you get people diagnosed, the earlier to the center where you can provide multidisciplinary care, which can impact survival and quality of life, the more opportunity for any potential benefit with the FDA-approved disease-modifying therapies, and more opportunities for inclusion in clinical trials. So that was nicely summarized. Thank you. And it's one thing to discuss data, and another to hear the impacts of the delayed and misdiagnosis from those personally affected. Let's take a moment to listen to two lived experiences with delayed diagnosis.
The first doctor I went to was my primary care physician, who diagnosed me with anxiety and low blood pressure. And that was her conclusion based on me telling her that my balance was off, I was having coordination issues, and my left foot was scuffing on the ground. It was extremely hard to shake the anxiety misdiagnosis. So my primary care doctor told me it was up to me and put the onus on me to see a neurologist. I did. It wasn't again until a year and a half after initial symptoms that I was diagnosed at a university hospital within a multidisciplinary ALS clinic. I almost didn't make the cutoff for a promising clinical trial right near me. So it is imperative that, doctors see the signs and take us seriously immediately, as time to diagnosis has such a domino effect.
I am speaking on behalf of my mom, who was diagnosed in May 2016 with ALS and died in March 2017 of ALS. Initial symptoms were tripping and falling, first by dragging her right foot, then her left, then her handwriting got shaky. She was never sent to a specialist. Her primary care doctor diagnosed her with spinal stenosis and recommended back surgery. Her recovery from back surgery initially went well, but then her progress in physical therapy started to decline. And at that point, which was approximately 6 months after spinal stenosis surgery and 1 year after onset of symptoms, she was sent to a specialist who suggested it could be ALS, period.
So these lived experiences really point out the impact of diagnostic delay in people living with ALS. And both had tripping as their initial symptom and asymmetrical lower motor neuron weakness, but very different initial thoughts about what might have been causing it. Dr. Novak, do you think that this is something that you see often? And what did you think about some of the procedures that one of the patients experienced?
I think this is entirely too common. We see a lot of patients who have, subtle signs at first, and if you find something on a scan that maybe looks like it could be related to a stenosis, I'm sure you'll find someone who will try to fix it. And I see several patients a year probably who give a very similar story, especially to the second one of, we found something, maybe that's a problem, we're going to operate on it, and seem to maybe get a little bit better, like they feel like they're doing okay. And then as disease spreads, they start to see a decline. And so now they're done with therapy after their back or knee surgery or whatever it may be, they're getting a little bit worse. And now that's when you start to hear now my arm's doing it too, or my other legs doing it. And that often prompts the neurology referral at that point after, they've spent 6 months working on one diagnosis. So I think we see that a fair amount. I think the first patient experience is just a shame that they didn't get referred for at least, first level testing that would have found some sort of nerve problem with her foot. And then, maybe that leads to more, but I think that's a case of, more just not recognizing the possible disease. They just kind of missed it. And I think waiting a year, like Dave said here, is very common.
Yeah, I think the other point in one of the discussions was about, the diagnosis, maybe it's ALS, probable ALS. And I do struggle with our existing diagnostic criteria. We'll get to some of that a little bit later, but one of the things that I often get asked is, oh, okay, so I saw that I was classified as probable ALS. So does that mean I don't have ALS? Or is there a possibility I don't have ALS? How do you respond to that?
Often by not putting that in notes. I don't like putting that in the note because patients can read that and they can say, oh, well, it's just possible. So, I try to tell patients a little more directly as far as I think this is what you have. And I try to leave the Escorial and those types of criteria that categorize patients like that more for research purposes or for a clinical trial type thing. And if you're going to put that in a chart or you're going to say that, you got to explain it. You have to explain that to the patient because they do see those things, and it causes quite a bit of confusion.
Yeah, our traditional criteria, I always try to explain even to other physicians and other healthcare providers that, our diagnostic criteria uses these terms: suspected, possible, probable, definite. But when we're applying that criteria, we've already presumed that the person is already considered to have ALS, but we're kind of assessing the disease burden on their body, right? And the regions affected. But the terminology can genuinely be confusing, and we'll kind of get to what we've done to make it easier or hopefully better for the future. But we've seen and heard how much the impact can be in a delay in diagnosis. So what are some things that we can do to reduce the diagnostic delay in our healthcare system?
So I think we've got to do, I guess, three main things. The three biggest things we can do is get education and word out on how to recognize the early signs of ALS. These patient cases and the studies that we've reviewed so far have shown quite a delay before getting to a neurologist. That means other physicians are dealing with these patients and they're working up their diagnosis. We want them to at least consider ALS, and we'll talk about how we can do that. I think, one of the second biggest thing is getting referrals to ALS centers quicker, and that will help. And then I think we really need to simplify our diagnostic criteria, which we have some, thoughts on how we can do that and moves that we've just as a community recently made. So hopefully we can work on all three of these things.
Yeah, I think you pointed out that you really want to get that diagnosis and referral as soon as possible. So let's talk about how we can do that with the Think ALS tool. So I wanted to talk a little bit about that.
So this has been put out by the ALS Association really just in the past couple months. This is a fairly new tool that they put out on a website, so you don't have to keep a piece of paper or lose it or whatever. We really want our clinicians to think ALS. And so they can go to the website called Think ALS, where you can run through some symptoms in basically checklist format to see how concerned should you be as a non-ALS physician about someone having ALS. So anybody with, progressive weakness, especially asymmetric weakness. So they're getting weakness in a limb, probably going to be fairly early on in their course. But if that's their complaint, it's worth going through this sort of checklist to see how concerned you should be. So in the first box, it stratifies patients as either limb onset or bulbar onset. So for the limb onset, ankle weakness such as foot drop, hand weakness, or even proximal arm or leg weakness. So legs dragging, shoulder weakness, any of those, especially in someone who has atrophy of that limb or fasciculations and cramps in association with this developing weakness. If bulbar onset, some of the symptoms we've talked about with slow or slurred speech, dysphagia, emergence of pseudobulbar affect type symptoms, which would definitely trigger you to think neurologic issue, excess saliva, or the tongue fasciculations that we talked about. Anybody with any of these symptoms should immediately be concerned. The physician should be concerned that this could be ALS. If you look at the second box, or what's categorized as C, to support ALS, people with family history, lots of weight loss, unexplained, falls or neck weakness, which there's not a whole lot that would cause that, besides neurologic disease, respiratory insufficiency, so mild symptoms, just when they're laying flat or doing activities, they're feeling a little short of breath. And then the big one, I think, at the bottom is really the hallmark of ALS on exam, is the hyperreflexia with atrophy and weakness. Anybody with this kind of mixed picture, you immediately got to think ALS. So if you've got a couple of those checked, and then not a lot in this last box is D, which would argue against ALS, radicular pain, symmetric weakness, people with a lot of sensory loss or signs of movement disorder, like Parkinson's type issues with cogwheeling, or rapid onset with no progression. So they get really weak, they get really symptomatic, and then they just kind of plateau. Those would kind of argue against ALS. So if you've got a couple things in the first box and maybe one or two in the second and not a lot in the third, that's someone that you would really be concerned about ALS. And this is, kind of leading someone through our thought processes. And then at the end of this, also giving you a list of referral centers to get the patient sent to. So not only thinking about it, not only being concerned about it, but knowing what to do with the patient after that to get it worked up as quickly as possible.
Okay, so in the best case scenario, we got our Think ALS tool, the PCP or the outside physician refers to you within weeks instead of months, right? And gets them to you with the proper testing done. Why is that important to get to a multidisciplinary center as soon as possible?
Well, because I think we are going to consider it much sooner. If it's on our minds, we're going to work it up in a different way. A great referral is someone who says concern for ALS. They don't have to diagnose them, but just put it in the referral somewhere, because it's probably going to get routed to an ALS specialist who's going to see the patient sooner and approach the patient a little bit differently. I think a general neurologist might just approach foot drop as looking at one limb, where we might look at multiple limbs and even bulbar muscles, and really trying to stratify how far has this disease progressed, even though they're not symptomatic. So I think we approach the patients a little bit differently. And it turns out that, we diagnose them faster that way. The study on here now, it looked at 166 patients that were sent to an ALS center in Spain, and really kind of stratify how fast people got diagnosed by where they got sent in neurology. So even if you get sent to neurology, we want them sent to an ALS referral center, because on average, they got diagnosed at 8.6 months versus 12 months if they went to kind of the general neurology route. And I think a lot of that has to do with, getting sent to neurology, maybe general neurology, who might do the first EMG, might do the MRI, start the blood work, and then say, "Ooh, I think you might have this," and then send them to the ALS center physicians, who will then confirm the diagnosis. So we want to skip that whole first step and just get them straight into us. My general clinic spots, because I still do general clinic, I have about a 3 to 4 month wait. If I get a referral that says possible ALS, I'm probably going to see him within a week, maybe 2 weeks. And often it'll be a combined EMG and consultation, especially if they're coming from far away, that you can do the testing, the consultation, order the next appropriate testing, and you may have someone, fairly well confirmed to have ALS within a few weeks of referral as opposed to months. So we really want to speed that up by kind of skipping over and coming straight to us if we can.
Yeah, you highlighted the need really to recognize it and presented the tool, the Think ALS tool, for physicians to really be aware of the symptoms to make that referral quickly. And we've highlighted how difficult it is to diagnose the disease without a diagnostic biomarker or a diagnostic test. And so that leads us to a point where we need to kind of look again at our diagnostic criteria for ALS. And it's important to note that some of the greatest delays and variations between centers were seen in the 25% that don't fit that AWAJI definite criteria at the time of clinical diagnosis. So we still really have a problem in the ALS community because of the diagnostic criteria itself, which is an evolution. So I wanted to talk to you a little bit about the current AWAJI criteria and maybe move from there to talk about how that's evolving.
So the AWAJI is still, using the 3 categories, but does allow for EMG data to be, considered for the lower motor neuron pathology portion of it. But you're right, it still offers that little bit of subjectivity and a little bit of confusion over the 3 different categories. Fortunately, we've got a newer one that has just come out as far as diagnostic criteria that hopefully helps clarify some of those issues. So the Gold Coast criteria was published, I think, in 2020. So this is pretty new. And actually the 2 presenters for the next 2 portions of this 3-part are authors of that. I did not get to go to Australia, and I don't think you got to go either, did you, Doug?
No.
No. So they got together and they came up with this. So I feel somewhat odd presenting this one, knowing that they wrote this basically. But this is a effort to take away the 3 steps and the 3 categories and just classify people as yes or no. Do you have ALS or do you not? And so it is now just a clinical diagnosis, not a categorization process. And the way they're going to define it through this criteria is anybody with progressive motor impairment, documented either by their history, so they say they're getting weaker, or by repeat clinical exam, and they previously had normal motor function. So that's pretty broad range. Anybody that's getting progressively weaker, but then you add in that they also have upper and lower motor neuron dysfunction. So at least one body region. So that already makes it a little more sensitive because we're going to include people with only one limb or one body region affected if they have the upper and lower motor neuron pathology findings on exam in both areas. And then, of course, ruling out other possible diagnoses. So, that's still a broad category and fairly vague, but that's pretty much what we have to do as neurologists is, rule out everything else. And so people who fit those criteria, we can classify them as, yes, it is ALS. And it's a little bit more straightforward. And I think this is what a lot of docs have done who didn't like following the Escorial criteria. This is what we did as a doc, saying you have progressive weakness, you are getting worse, you have this mixed pathology, I can't find anything else, you have ALS, and worried less about, well, it's in this area versus this area and that area. So I think this is a little bit more of a common sense approach. And I think it's a little bit more of what we did in probably clinical practice outside of clinical trials, where they have to have those, very strict criteria.
Yeah, I think the Escorial criteria had been become. I think the intent was really to make it clinically useful, but it really did help more on the research clinical trial side to kind of make sure the populations being evaluated were similar in disease burden when they started a clinical trial, and so you don't get too much variability as a clinical trial would progress. And then the AWAJI criteria came along, and then of course the Gold Coast. Just a piece of trivia, all of those names are derived from the locations where the meetings were held to come up with those diagnostic criteria. And what I can say is that the clinical trial community has been pushing towards using the Gold Coast criteria as well for clinical trials, hopefully to be more inclusive. And hopefully we will be able to refine outcomes and be more successful in clinical trials when we develop biomarkers. So I think I wanted to ask you a little bit about what you felt about the diagnostic utility of the Gold Coast criteria. There was even a more recent publication about that regarding the sensitivity and specificity. Yeah, go ahead.
So this is come out since then, looking at the diagnostic utility, where kind of a busy slide, but it does break down pretty easily. You know, starting at the top, you have 506 patients who were assessed for ALS. And within that group, it was considered that 350 did have ALS and 156 were, you know, some sort of mimic of ALS. And they put them through all three criteria to look to see sensitivity and specificity of them. And, you know, what we learned was the Awaji and the Escorial were very similar in how they behaved, where looking at down the middle, 506 patients put, you know, reviewed by the Awaji criteria and whether they had probable or definite. So they took the top two tiers. 191 of the 350 ALS patients were picked up by that criteria. So under probable, they have 191. So they didn't get any mimics. It was very specific for ALS. But looking at the patients that tested negative through the Awaji criteria, but did have ALS, there was 159 in there. So not very sensitive, you know, probably not picking up patients in the early stages would probably be what happened there. In the Escorial criteria, it was very similar. You know, they had 163 that were categorized as probable or definite. And on the negative side, you know, 343 did not categorize as either probable or definite. And of that, 187 did have ALS. So not very sensitive in picking those patients up compared to the Gold Coast criteria on the left, where, you know, 340 were considered to have ALS. Of that, 322, you know, did truly have ALS. So picked up a lot more patients than the other two did at 191 and 163. Essentially, you know, patients that were considered negative on the Gold Coast criteria that did have ALS, there was only 28. So they picked up a lot more. They picked up a few extra mimics as well, you know, 18 that were considered positive. But as far as sensitivity goes and picking up more of those patients, much better job and much easier to follow. I think as a physician, you know, I think this will help physicians who don't deal with those criteria constantly and have them, you know, ingrained into their brain at night, make the diagnosis easier.
Yeah, I think in that publication, it was clear that the sensitivity improved with the Gold Coast criteria, and also it was pretty effective in picking up some atypical variants of ALS that often get missed by the more stringent criteria from previous versions. So I think this would be hopefully a more useful tool, both in research, but also for clinical practice as well. Let's summarize with our SMART goals. That is what we hope our audience will take away from this presentation to apply in clinical practice. ALS is a progressive and fatal motor neuron disease with significant delays in diagnosis. When the diagnosis is delayed, it reduces treatment efficacy. It can hinder access to multidisciplinary care, and as you've heard, can impact quality of life and survival. It could also reduce the opportunities and chances for people living with ALS to enroll in clinical trials, since many of the clinical trials require people in early stages of disease. Clinicians and healthcare teams can reduce the diagnostic delay by using screening tools to recognize early signs of ALS, immediately referring patients with clinical suspicion of ALS to multidisciplinary centers, and applying a simplified diagnostic criteria that maximizes early and accurate detection. This CMEO snack is one of a three-part series. We hope that you'll take advantage of all the short and focused activities in the series, including the role of genetics in ALS, who should be tested, and emerging gene therapies in the fight against ALS. Thank you again to my colleague, Dr. Novak, for presenting and having a conversation today. And thank you to all of you who joined us. Be safe and take care.